Okay. Well, welcome again to everyone who's joined us already this evening. I'm Mindy Blue-Packa, the Chief Community Impact Officer at Fairfield County's Community Foundation. And our foundation's mission is to enable everyone in Fairfield County to thrive. I'm very pleased to welcome you to the first part of our three-part series, Listen, Learn, and Engage: The Path to Better Healthcare Access in Fairfield County. This series is co-sponsored with our partner, the Universal Healthcare Foundation of Connecticut. Access to healthcare is essential to individual and family well-being, and therefore it's one of the foundations of a thriving community. The COVID-19 pandemic laid bare the many structural challenges with access in our current healthcare system, and many individuals, small businesses, nonprofits simply cannot afford adequate healthcare. So in this three-part series, we will explore the problem at the ground level, potential solutions, and how you can help our community improve our neighbors' access to healthcare. So without further ado, I am delighted to introduce my colleague, Francis Padilla, President of the Universal Healthcare Foundation of Connecticut, who will introduce our guests and lead this evening's discussion. So Francis, I hand it over and I leave them in your very capable arms.
Thank you very much, Mindy. It's really a pleasure to collaborate with you and the foundation. Universal Healthcare Foundation of Connecticut has as its core mission the access to quality, affordable care for everybody in our state. And we work in partnership with many organizations to achieve that goal. So I'm going to start us off with a very high level overview of the concerns people have around healthcare in Connecticut. And then I'm going to introduce our speakers this evening. So our health is one of the most important personal assets we have because it allows us to get up every day and strive for the things that we care about. It contributes to how well we thrive at school, at work, in our families and communities. Many of us can get through life without the need for a lot of health care, and others of us need large quantities of health care at certain points in our lives, or even continuously. It is usually when we need to interface with health insurance, doctors, hospitals, and pharmacies that we realize how disconnected the various parts of the system are from each other, how many barriers there are to getting what we need to maintain our health, and how weary, sicker, and poorer it can make us to navigate it all. The experience of healthcare in Connecticut and in the United States depends on where you live, where you work, the color of your skin, and the language you speak, whether you are a citizen or an undocumented immigrant, and how much money you make. 1 year in, the COVID-19 pandemic has borne this truth out over and over. Connecticut has world-class medical research and science, but its healthcare system consistently earns C's, D's, and even F's on national measures of access, quality, and cost. The main issues people in Connecticut encounter are the high cost of insurance premiums, deductibles, and copays, the high cost of prescription drugs, lack of access to care, even when they have insurance or are covered by state Medicaid, and variations in health outcomes due to quality of care. There are also significant disparities in health outcomes by race and ethnicity. There are considerable structural reasons for these system failures, and we'll talk about those in the next discussion on March 18th, so I hope you have your calendars marked to come back. First, we need to better understand the lived experience of everyday people and let that serve as the foundation for understanding where the system fails and how that impacts people in real ways. Tonight, we're going to have a conversation about some of these experiences from the perspective of a family doctor, an entrepreneur, and the leader of a nonprofit organization serving immigrants. I have the pleasure of moderating this conversation with Darer Littman formerly of Greenwich, now of Milford, who is self-employed as a writer and author, and who also lived 15 years in the United Kingdom, where there is a system of universal health care. Dr. Steve Smith, a longtime advocate for universal health care and health systems change, and a practicing family physician at Community Health Center, Inc. in New London, also a member of the Universal Healthcare Foundation Board. And Susan Schnitzer, I'm sorry, I tried pronouncing that several times today and it came out perfectly. My apologies. Susan is president and CEO of CIRI, Connecticut Institute for Refugees and Immigrants in Bridgeport, providing services for over 100 years. Now, one last thing before we start. We want you, our audience, in the conversation. Please enter your questions into the Q&A function at the bottom of your screen to the left of the chat function. We'll try to answer as many of your questions as possible. And now, let us get started. Sarah, would you tell us about the challenges you've encountered having to buy your own insurance as an entrepreneur?
Hi, I'm Sarah Darer Littman, and I really want to thank everyone who's here tonight to listen to our stories. So I am a sole proprietor. I am an author. I have been a journalist and columnist, and I am an adjunct professor at WestConn in the writing department. I am married to another sole proprietor. So both my husband and I have an entrepreneurial bent. And we are stuck in that middle class trap of making too much to get a subsidy, but not enough to really, to be able to thrive when we're paying this much for health insurance. So to give you an example of what we were paying in January of 2020, we were paying $2,592 a month, which is $37,000 a year. And that was for a high deductible plan with a $7,000 family deductible and high copays on visits and on prescription drugs. Before someone says, oh, well, high risk pools might be a solution, I want to give you my lived experience that they are not a solution. When I moved back from the United Kingdom in 1999, the only healthcare that we were able to get, because my then husband was a type 1 diabetic, and I had suffered depression within the last 10 years, was the high risk pool. And it was extremely expensive. It had no prescription plan. So we had to lay out money for all, my ex-husband's diabetes supplies, which, as you can imagine, are not cheap. And then we had to get reimbursed for everything. Well, unfortunately, because of the kind of games that health insurance companies play with cash flow, it became almost a full-time job just to get reimbursed. And at one point, they owed us over $10,000 in unreimbursed claims. At which point, I wrote to the chairman of United Healthcare and copied it to my senators and congresspeople. And all of a sudden, lo and behold, the checks started arriving. Now, I am a well-educated native English speaker, and I had the wherewithal, to be able to withstand that kind of, cash flow hits, although it wasn't comfortable. But I also had the wherewithal and the knowledge of how to advocate for myself. And not everyone has that. So I want you to bear that in mind when we talk about all of these healthcare issues. The reason why I told you January 2020 was because in February 2020, I received a special appointment to teach full-time at WestConn. Now, special appointment, I just want to let you know, the maximum it can be is 2 years. And it's on a semester by semester basis. You have no, you don't know whether you're actually going to be full-time the following semester. But I took that opportunity because of our health insurance costs, and it changed our lives. Being on the state of Connecticut plan, we went from paying $37,000 a year in premiums to $2,183 a year in premiums, and our deductible and copays were much lower. So, suddenly we had more disposable income to spend in our community, to, give to charity, to do the things that we really wanted to be able to do. But, obviously I realized that a lot of that premium was being paid by, the state of Connecticut. I am no longer, because this was a temporary appointment. I just finished I extended the amount of months that I was receiving my salary over so I could keep my health insurance as long as possible. But I went off of it at the end of February, and I am now on COBRA, which is it's basically $22,320 a year. Now, while that's a lot more than I was paying while I was employed, it's still $15,000 less a year than I was paying when I was getting my insurance through Connecticut. And not only that, it's not a high deductible plan. So, that change, it still changed our lives, even though it's not a permanent solution. So in August of 2023, when our COBRA expires, I'm going to be 60 years old, which means I still have 5 years before I get on Medicare. And the thought of going back to a high deductible plan is absolutely devastating to me now that I understand how the other half lives. So to say I was disappointed by the insurance committee vote in the legislature today is a massive understatement. I am furious about it. And I really hope that we will be able to fix this in the other committees. I hope the legislature will listen to the voices of people like myself, my husband, who are hardworking taxpayers. Mm-hmm. And I hope they will listen to us, not just the big insurance companies. Thank
Sarah,
you.
Thank you very much for that. And that trajectory is really pretty remarkable. And the kind of outlay is equivalent to maybe not as expensive as sending our children to college, but certainly up there.
Close.
In terms of expense. But you mentioned what happened at the legislature today. And although we're not going to delve too deeply into the policy solutions in this conversation, I think our audience probably may not know what you were referring to. So could you just take, 60 seconds and explain what you were referring to?
So what I was referring to was that that they had agreed some amendments to the bill.
Well, there is a bill in the legislature.
Yes, sorry,
for
yeah.
Public health plan, right? Mm-hmm.
Right. So the head of the Senate committee and the head of the House committee, both the head of the insurance committee, both Democrats had agreed certain amendments. And then in the committee today, the chairman of the committee, Kelly Wood, totally blindsided everyone and offered a voice amendment, an oral amendment, which basically gutted the whole idea of offering this public option, which has literally changed my life. And I feel I'm almost shaking because I'm so mad about it. So I really hope that the legislature will listen to our stories and do something to fix this.
So thank you for that summary, that overview. The legislature is trying to create some additional ways in which individuals, sole proprietors, entrepreneurs, and small businesses with fewer than 50 employees, as well as nonprofit organizations of any size, could have the opportunity to buy affordable coverage for themselves and their employees without with good quality benefits and not breaking the bank. So that's a story to be continued. I'd like to turn to Steve. Steve, would you please share with us what you see day to day in your patient's experience and why you think a systems perspective is so key?
Thank you, Francis, and thanks to the hosts of this webinar. It's a wonderful thing and very pleased to participate. So when I was asked to come up with some stories, I have to say that's not a hard thing to do. I have this little book, and whenever a moving story occurs to me in my patient care, I kind of write it down. It didn't take more than a couple of days to come up with some compelling stories to share with you today. I have UConn medical students who work with me each week, and I tell them, the science is the easy part. Now, those of you who think about, doctors going to medical school and so on must think, oh, what is he talking about? You have to learn all that anatomy and physiology and so on. Well, you learn it and it doesn't change, and it's there. What changes and is so challenging is the human stories that we have to confront, the system challenges that we have to confront. And to give you an example, this week, a 27-year-old woman came to see me. Actually, it was a telehealth visit. She's Hispanic, Spanish speaking, and she had a cesarean section on February 25th. She was in a great deal of pain, and that's why she called, because she was completely out of medication. She had called her obstetrician who had done the C-section and had not gotten a call back. She does not have insurance. She was told the last time she was in the office that if she came back, she had to bring somebody who spoke Spanish and who spoke English and could translate for her. And she was really, really desperate. Our office called the obstetrician, and guess what? We got her an appointment. We called her back, gave her the time, and she's going to follow up. And this is not a unique story. I've heard from many of my patients who are either uninsured. Almost all of my patients are poor. If English is not their native language, that they don't get the kind of treatment that they deserve. Treatment that we would be outraged about if it occurred to us. And in fact, it's not only outrageous treatment, it's illegal treatment, because there's a law called CLAS, C-L-A-S, that says that any practice that accepts Medicare or Medicaid payments have to provide those linguistic services to the patients. But it's completely ignored by so many practices. And it's a matter of, for them, a matter of economics. Why should we be paying for interpreter services when we can get by without it? These are the things that just boil my blood, and I have to deal with every day. And that's just one of many unfortunate stories.
Well, thank you, Steve. Yes, you see them firsthand, and we unfortunately have a very deep well of stories in Connecticut. Susan, why don't you tell us your story of Siri's experience working with refugees and immigrants, and also as a nonprofit organization with employees that also need health coverage. I'm sorry, my phone is ringing.
That's okay, certainly. And thank you, Francis, and thank you, Sarah and Steve and Mendy for inviting Siri to join this important conversation. As Francis mentioned earlier, Siri's been welcoming newcomers to Connecticut for over 100 years. The past several decades, our focus is on resettling refugees, working with immigrants and survivors of human trafficking. So like Stephen, we work with very vulnerable populations, and we have a firm understanding of myriad challenges that folks have with getting affordable health care and accessing health care. And this has only been exacerbated, as you said, Francis, by the COVID-19 pandemic. For some of our clients, it's the lack of access to health insurance, the ability to have insurance primarily for the undocumented population, which really spans a broader group than most people would think. And then also the understanding of services that are available and how to access those services that are available through community health clinics, such as the one Stephen works for, who really help literally save the lives of our clients. And, you know, I'd like to just share a couple of client accounts so people can understand. And remember, these two stories I'm sharing, they have caseworkers. They have a team of people working with them to help. So they're not on their own. So in that way, they are a bit fortunate. But let me share the stories with you too. So the first, and I've changed the names, obviously for our clients' privacy. But one of our clients, Abel, he's a 40-something-year-old man. He came to the US after being subjected to both personal and community violence in his home country. And his current immigration status makes him ineligible for public health care. He has not been able to secure work authorization, which he so desperately wants so he can join the American workforce. His case manager at Siri connected Abel with a community health center due to issues with his teeth and his mouth that were the result of the abuse he had suffered through many years and the lack of dental care. And as many know, and I think Steve can attest to, your dental care affects your health. Well, he wasn't able to find free or low cost service to fix his issues. So he could only fix half of his mouth, and had to do that because he wasn't able to eat. He had to take everything through a straw. And even in doing that, he had to make those decisions between what he was eating, where he was living, and the ability to afford health care. So while some of his problem is fixed, he's still living with this debilitating pain that's causing headaches. And we worry that it will cause other issues where, you know, if he had insurance, it was a $6,000 fix. Insurance would have paid for most of that and really allowed him to move on with his life and move forward. The second story I'd like to share, and again, I'm sharing these because they're also very common that we're seeing with our client, the common stories throughout our client base. So woman Esther, who's a survivor of domestic violence and labor trafficking, she was brought to the U.S. against her will. And secured safety through Siri's Project Rescue program. She was carefully saving her wages so she could bring her children up to the US and reunify with her family. And then she encountered an unexpected medical condition, which put her in the hospital. She then lost her job, so lost her income and had to use all of her savings just to pay part of the hospital bills and just to try to survive here. So now she's not able to bring her children up. So her young children are no longer with their mother, and there's no hope now for them to be reunited with their mother. And again, we're not telling these stories to shock people, but to really present to you the decisions that folks need to make between physical health and very basic needs, and also being able to be a parent to your own child. And these challenges aren't just with our clients. We have, as you know, a lot of nonprofit leaders and workers know, working in nonprofit, none of us do it for the money, fame, or glory. And we have to make decisions as workers in healthcare sometimes, you know, what type of health insurance are we going to get for ourselves and our families, and how do we work that within our own family finances, and also as an agency, right? I mean, it's a horrible conversation to have every year. How much are you going to be able to care for your colleagues' health and then the financial health of your agency? So we fully support all the efforts across the state to make affordable and decent health care available for everyone.
Well, thank you, Susan. Those stories are heart-wrenching. And, you know, today, the Human Services Committee of the legislature heard testimony from many, there were 186 people signed up to give testimony. Some of them were, of course, in opposition to a bill that would open up Husky programs to immigrants and regardless of status, right? There's 130,000 undocumented immigrants in Connecticut, and there are many others who still cannot afford health insurance. And the stories there were also wrenching.
Yes, I can imagine.
That while it is true that there are legislative initiatives underway. Sarah mentioned the public option, and that includes both an insurance plan, but also subsidies for individuals like yourself, Sarah, to be able to, you know, if over a certain amount, to be able to qualify for subsidies. And the expansion of Medicaid Husky programs to the undocumented, and also to people who earn over twice, up to twice rather, the federal poverty line, because in Connecticut, you know, the federal poverty line, it gets consumed easily in Connecticut just with housing costs.
Of course, yes.
You know this well, especially in Fairfield County. And these efforts. And so I want to take this to the systems issue and maybe bring Steve in on this, because Steve has given a lot of thought to this. The need that people have has to be addressed in a much more coherent, systematic, and systems-oriented way. So Steve, can you say something? Can you speak to why you really feel that the ability for the state to step up and protect patients and consumers is so critical to moving forward on this issue?
Sure, Francis. And one of the things to think about is that all the stories that I am telling you are about people who already have reached out and become involved in a healthcare system. There are so many patients or people out there who aren't connected at all, and their stories are even more compelling. So you know, access to care is the first step, being able to actually do that. And there are so many barriers. There are transportation barriers. I can't tell you how bad the transportation system is for people who don't own a private car. Between the bus system and the state-supported, sort of medical taxi system, it's terrible. People miss appointments all the time, and then their provider said, "Well, you can't come back to see me again because you missed your appointment," and it's no fault of the patient at all. So the very first thing is getting people into the healthcare system, where we can assess their needs, where we can try to be advocates for them, where we can try to bring the medical care that's needed to them. And leaving it up to the commercial marketplace is no answer. So it is vitally important for the state to provide access for vulnerable populations. And I didn't know about. I've been working all day, so I didn't know about the committee. It's like a punch in the stomach because the public option, it's not a panacea, but it would be a huge step forward in the long game, because we really have to be thinking about the long game to achieve universal health care. I always tell this joke, but I'm going to do it now. There was a health policy expert like Francis, okay, who, and no intention here, but who died and goes to heaven. They say you have a chance to talk to God and ask God a question. So the healthcare expert goes up to God and says, "God, will there ever be universal health care for the United States?" And God says, "Yes, but not in my lifetime." So, we wonder about that. Will we ever get it? But I do think we're making step-by-step progress, and the public option was one more step in that way. The other thing that it does is add more competition. The commercial plans right now, they just what they call shadow price each other. So if one company has a premium of this much, the other company has a premium of that much. And no matter how much the increase is, whether it's 10%, 20%, 30% increase in premium, it's just passed along to the consumer. And as Sarah was saying, that becomes unaffordable. You know, you had the fortune, Sarah, of living in the United Kingdom for a while. Many of the issues that we're talking about, how do we afford healthcare? Those are inconceivable questions for people living in most of the developed world. You know, when they get sick, they want to be able to take care of their health. They don't want to be thinking about, can I afford it? What do I have to sacrifice to do this? We have a long ways to go for there, but it's vitally important that we do.
Well, you know, the other countries where no system is perfect, right? So the Canadian system, the English system, the German system, none of them are perfect, but it's about values. It's about what does the society value, and it values health, and it values the ability to get care without going into debt or dying because you can't get care. I think that I want to talk a bit about the fact that this is for everyone, right? You, Sarah and Susan, and Steve and me, we're all middle-class working people who through our employers we're able to get our coverage, and we are struggling. There's a self-sufficiency standard in Connecticut that looks at what it takes to be able to afford to live in Connecticut and pay that household, budget. And in a place like New Britain, for example, you need to earn about $30 an hour to be able to afford rent, childcare, healthcare, transportation, insurance, food, the basic. And the average person, the average new job development in Connecticut over these last several years has been generating jobs paying under $20 an hour, right? So we're talking about working people. We're talking about people who are working and are still poor, who are working and may have insurance they can't afford to use. And that is a lot of folks. We hear those stories all the time. Yes, there are people without insurance and people who can't get insurance because of their legal status. Then there are people who actually do have insurance and can't afford to use it. And we were supposed to have a guest this evening who has really dealt a great deal with that issue. He had a family medical emergency that prevented him from being here, but a serious chronic illness in his family. He works for a small employer. He has insurance. Every year it becomes more expensive, even though the small employer keeps that insurance, pays 50% of the premium. And he and his family have over $125,000 in commercial credit card debt related to bills, medical bills. And how does a young family get ahead? How do they save money to send their children to college? All those kinds of things. So this is really a problem that affects us all. So I'd like to really think a little bit harder about what you, Sarah and Susan, think as, what would it be? I am prone to say that out of COVID, healthcare is key to the economic recovery of our state and country. So take me on. Do you agree with that? Do you not agree, and why?
I'll go, and yes, I agree 100%. And this year, we usually every year when we're doing our budget, we have a conversation of balancing the healthcare, and this year we didn't, because just to have that discussion seemed almost gross to have it, right? Because we're here, we're working. We never really closed down. So we are all expecting ourselves and each other to be here the very, very least we could do, aside from the PP and everything, is to keep the healthcare steady, right? We wish we could have done more, but to keep the healthcare steady. And the only way to open back up is for people to feel healthy and to be healthy and to feel confident that those around them have access to care and vaccines if that's what they choose to do. But I think people are looking more at community health, and I hope they are, right? And looking at their neighbors and caring about what their health is, not just within your own home and your own social groups.
We need that. Sarah?
So I'd like to bring up a few points. One, first of all, when we look at, coming out of the 2008 recession, small businesses were some of the drivers of, reigniting the economy. So that's point number one. And if small businesses are being, buried by healthcare costs, it's hard for them to grow, and people may not be able to afford to leave a steady job.
She froze.
With health. So that's one point. But another point that I think is equally as important, especially when you were saying about, the fact that the jobs that are being added in Connecticut are lower wage jobs. Part of the reason for that is, a lot of the health insurance companies, for-profit health insurance companies, are a major, culprit in the reasons for that, because I as a journalist, I did several, a whole bunch of columns about the fact that these companies took our taxpayer dollars, for, job growth, but then they outsourced middle-class jobs overseas. So a lot of these sort of middle-class jobs that actually paid $30 an hour, companies like Cigna and Aetna, they outsource them overseas. Mm-hmm. So it's kind of, it's infuriating. One other thing I just want to say to Steve's point about having lived in the UK, people get really freaked out. I find, like, sort of when I talk to conservatives about this issue, they get very freaked out about the whole idea of socialized medicine and about, you have to wait for, whatever, for a hip replacement. But in the UK, which is, and I want to add that Winston Churchill was actually in favor of the NHS, that well-off people will always jump the queue. They, well-off people in the UK have private insurance on top of their NHS, which they use to go to private hospitals where, I remember having a situation where I was going to have to wait for, like, I don't know, several months for something, but I could have the same procedure done by the same doctor, but at a private hospital the following week. Mm-hmm. So, well-off people are never going to suffer, even if we have socialized medicine, because they are still going to be able to afford private health insurance on top of it. So that's one of the reasons I get very frustrated by that argument.
What is true about other countries is that they do achieve better health outcomes at lower cost. And that actually allows them to invest in some of the society's costs for social determinants of health, right? Good housing and good transportation systems, for example, because healthcare actually does eat our lunch. The cost of healthcare is very high, and it does take away from other investments that are needed in society. I'm also interested, I think, in the discussion about, why all immigrants, regardless of status, should be able to get health care. Today was an interesting day. I started my day being interviewed by Channel 61, Fox Channel 61. There's a question in the Q&A, and I did want actually to encourage everyone to please put your questions in. I'm going to ask this one and then turn to that one. The question is, why should the state provide insurance to people who don't pay taxes? And I said, well, that's actually not true. Immigrants, including undocumented immigrants, pay a lot in taxes at the local, state, and federal level. So, Susan, do you want to address that in your experience?
Yes, so sure. And yes, that is true. Immigrants of all statuses pay into the tax system, and it's I look at healthcare, and I think all of us, as a basic human right. So you're living here, you're part of a community, your children go to school, you work here, you're paying into the tax system. Why is it not that you would have access to this basic human right in an affordable manner? It doesn't make much sense. It doesn't make much sense. I do have to say, though, that when we talk about the community health clinics also, and a lot of people don't know a lot about them, they're where we go, right? Some of our local hospitals, but the community health clinics are there to help everybody. They don't care about your income. They don't care if it's $100 a week or $10,000 a week. They are just there to help. And that is, but there's also a lot of pressure, right? There's a lot of pressure on those clinics because there are more and more people that can't afford to go to private practices. But that's kind of taking us away a little bit, but it does go with, if people have insurance, they have choices. They have choices of where to go. As I think, Stephen, you said, then we're working on the pricing. So you're hoping that the fee schedules will be reduced and that there'll be more fair pricing in the market. So that's why I feel it's important. Go ahead.
Let me just jump in because I just have to say that the patients who I see who are immigrants to this country, like my ancestors were, and like almost all of us are, unless we're indigenous, are some of the most hardworking people I know among my patient population. They are here because they saw the opportunity, just like my grandfather did in 1922, the opportunity to leave an oppressive country and come to America with a work ethic. And when you look up on a roof of a house, even in the coldest of winter days or the hottest of summer days, and those people tearing off the tiles on that roof, they're probably the immigrants that we're talking about, because those are the kinds of dangerous and difficult jobs that a lot of native-born Americans won't do. When we stay in hotel rooms and our rooms are clean, so many of my patients here in Eastern Connecticut work at the casinos and the hotels, doing the kind of work that a lot of, again, native-born Americans won't do. And that's just one of sometimes 2 or 3 jobs that they're doing to maintain their families. So I just, my heart goes out to these folks. These are going to be the soul of America, just like we as children and grandchildren and great-grandchildren of immigrants have become the basis of society here. And I will take care of anybody, even if they didn't pay taxes. I will even take care of Donald Trump.
Okay.
Who didn't pay taxes.
Didn't pay taxes. Well, there's a question in the chat that is about the community health centers. So going back a moment to community health centers and what is the role that they play in providing care to the uninsured, and what population still doesn't seek care from community health centers? Like, who's out there that is uncared for because even they're not even accessing the community health center?
I mean, we have a sliding scale so that patients can access our services at the community health center in New London, where I go, and it's part of a network around the state. But I will tell you one thing, and that is, even though we provide primary care, first contact care for our patients, many of our patients need specialist care. And this is, again, where the state has fallen down. I have a patient, another one on my book from this week, a lovely man, and he's late 50s with diabetes, and he's got spinal stenosis, which means that it's very, very difficult and painful for him to be standing or sitting for a long period of time. He developed what looks like a melanoma on his neck, and that's a malignant cancer, and it can be a deadly cancer. There isn't a single dermatologist in Eastern Connecticut who will see him because he's on Medicaid. Not that he's uninsured, he has the state insurance, but the fee isn't large enough for these struggling dermatologists to be able to take him. So the only dermatologist we could get him to have this melanoma taken care of was in New Haven. The problem is, for him to drive from New London to New Haven, his spinal stenosis just doesn't allow him to sit in a car for that long. What we finally figured out was we got the VO, which is the state sort of Medicab, to send a larger cab rather than a real, subcompact, so that he could lay down in the back seat from New London to New Haven, where he can be seen. But really, there is absolutely no need for him to have to go all the way 55 miles to New Haven when 1 mile from my clinic is a dermatologist. But that dermatologist won't see Medicaid patients. It's really a moral outrage, and it's not just dermatology.
Yeah, it is. It is really a moral question, a moral challenge that we have, where certain insurances are not accepted. And Medicaid, as much as we believe, first of all, that Medicaid ought to be expanded to more people, Medicaid is viewed by many in the specialist community as not paying enough, and they will decline services. And so that is a big issue. There's another question in the chat about what are the estimates of needed care that's never provided to populations who don't have insurance. So basically, what are the costs that would have been incurred if everybody who had insurance? I'm not sure that I can answer that question, but I will say this: if everyone had insurance, and I'll put this out to you all too, if everyone had insurance, there'd be the ability to go to primary care, to get primary care. Primary care is preventive. It helps the person get on an issue early before it develops into something more serious. So if we had everybody able to get primary care, we would have costs, but it would not be the cost that we have today.
Let me give you another example. I had I'm sorry, Susan.
No, go ahead, Stephen.
This man who has ulcerative colitis. I'm sorry, he had Crohn's disease. And this is an inflammatory disease of the bowel that causes people to lose small amounts of blood over a long period of time from their gut. And he had no insurance. He was a patient at Community Health, but he couldn't even afford the small co-payments that we require. His way of dealing with his Crohn's disease was to wait until he felt weak enough to come in, to get a blood transfusion. Well, most recently, it was about a month or two ago, he allowed his hemoglobin to drop to 4.3. Now, normally a hemoglobin's around 16 or 17 in the man. This is at near fatal levels. At that level, when your blood levels are that low, your heart can suddenly stop. When he came in, he was so weak, he was white, his heart was racing. We got him into the hospital. He had to be admitted to the hospital, have transfusions done. And, as you were saying, Francis, what could have been a small expense coming into primary care for regular care turned into, I'm sure it was, tens of thousands of dollars of hospital expense. And this is just foolishness in terms of even the economics and the finances of this. You know, they always say an ounce of prevention is worth a pound of cure.
Sure.
And that is so, so true.
Absolutely.
And we've seen with with a couple of people who ended up having cancer, but by the time they could get treatment, it was so far gone. And again, the expense of it, instead of catching it early. And I just want to comment a bit on the question about, at least in our experience, why we see people don't go to community healthcare centers. I think there's a lack of general knowledge that they're out there, and that they're open to provide services to all people. We are working with several healthcare partners to try to get information out. This is specifically COVID, but in doing that, these centers are out there, that you don't need any type of documentation status, and they're there to serve you the best that they can, right? And then, I mean, here, cheers to you, Stephen, for really working with your clients and getting them what they need afterwards. But you have to have that connection to just even know to go there, and then have somebody help advocate for you. So there's a lot of education broadly that needs to happen.
What you bring up reminds me of work that has been happening in Connecticut to hire and certify more community health workers.
Yeah.
And what I heard in Steve's description of that story, it was real personalized care, real coordination of care. That doesn't happen, and it doesn't happen for anybody in our system. When I first started out, I talked about how we have these disconnected parts of our health system.
Mm-hmm.
And if you are not able to advocate for yourself, or you do not have someone who has the psychic energy and the intellect to advocate,
Mm-hmm.
it is very, very difficult to coordinate the care. So these community health workers are people that are trusted in the community,
Yes.
who are really a liaison between the patient and the system, and really would make a difference for everybody. My mom was sick for a long time. I always say, like, I'm smarter than the average bear about healthcare, and I would be reduced to tears sometimes, dealing with these doctors and these different systems. It was awful.
It's very complicated. And then when you add on top of that lack of knowledge, and if you're an English language learner and can't
Right.
speak English, and maybe have some languages that aren't common to be supported in certain centers, it can be a challenge. But I do have to say, here in Bridgeport, our community health center, we have worked really closely with, and they do a really good job of trying to meet our clients where they're at. But again, that's the relationship that has been built. So we, as educated or not as educated about the healthcare experience as we're very educated and passionate about advocacy. But I think really important to reach folks that don't have a connection to a social service agency that has the capacity to advocate for them.
We've talked about coverage and the importance of coverage.
Mm.
I think a lot of what we've also talked about is quality of care,
Yeah.
right? And a system that actually functions as a system. And, we've talked about affordability on a sustained basis. These are all issues that have their roots in the structure, the way that healthcare in our country has been designed.
Mm-hmm.
And it may not always have been this way, but the healthcare industry is outsized. It is driven by Wall Street expectations, whether it's the hospital systems or the insurers or the pharmaceutical companies. It is very, very much driven by financial interest. And those financial interests have a lot of political clout because they want to preserve their place. And so when we talk about the experience of individuals like your clients, Susan, your experience, Sarah, you know, the multiple issues, health issues in your family, and you trying to figure out how to get coverage that didn't leave you out in the cold. Steve, your patience, it's not about, the problem is not the people. The problem is the system, it's the structure. And this is where our country has to take a really hard look, and there has to be a demand for change. The system is not designed to change itself. I heard someone say that, you know, the system actually is like the fox in the hen house. It is given way too much authority by state and federal government to regulate itself. And it won't regulate itself in ways necessary to make it work for the least of us. And if it works for the least of us, it works for all of us, right? So I'm gonna start to wrap us up. And if there are any other questions from our audience, feel free to put them in the Q&A. I haven't seen any more, but I would like to give each of you three an opportunity to send a message out. What do you want your friends and neighbors and colleagues to say to our policymakers about this situation? Any one of you can jump in first, or I'll call on you.
I'll go first. So that healthcare for all benefits everybody, right? Even those that have healthcare, even though it benefits everybody, and it's needed. It's needed, you know, to rebuild from COVID. It's needed to move forward for all of us to have healthy lives and healthy communities. And I do, you know, it's not just because Steve's on this call, it's because I feel very passionately, you know, we need to celebrate medical personnel that go the extra mile, that go above and beyond. And we've been very fortunate to have those folks in our community helping with our clients. But also to know that, you know, everyone has capacity. So I think we put too much stress on systems where there's an opening without enough support for those systems. So I would say more support for the systems, healthcare for everyone, and also the education, because you can't get healthcare if you don't know that it's there and available for you.
Okay.
Well, thank you for the plug, Susan. I would want to say, and I say this as a physician, that the disease system that we have, that I'm part of, is really not the answer to better health. It's a part of it, but it's not the major answer. And I think Francis earlier alluded to what we call now the social determinants of health, that really to be healthy requires a much broader context. Things, you know, like clean air, clean water, education, a reasonable housing situation for yourself. These are all so important. But nevertheless, the lack of access to healthcare for everyone is, to me, the most glaring moral deficiency that we have in this country. And we need to address that first and foremost, at least make everyone equal, just like we do with education. Now we would think, you know, it would be unconscionable to say some people can educate their children, but other people cannot. Maybe 150, 200 years ago, that wasn't the case, but we've morally progressed to the point that public education is now considered a given for everyone, a tax-supported public education system. We need to, whether it's tax-supported or some other way, we need to make sure that every person living in America has access to healthcare first and foremost. Make your voices heard.
Sarah.
Well, I want to follow on from what Steve said in that I agree that this is a moral issue. Who are we as a country? You know, we are the only like, you know, highly industrialized country that doesn't have some form of, you know, healthcare for all. And is that really who we want to be? The other thing that I would say is that I have noticed that the healthcare insurance lobby is advertising extremely heavily on television. So I would beg that our legislators, you know, recognize that and listen to everyone, not just the ones with the money to have the loudest voice.
Really important, really important. Well, you know, the next session, which is on March 18th, a week from today, is going to focus on what can be done to deliver on the promise of better health, better care, and better costs, and what are the barriers that are keeping us from equity. And I think a lot of what we discussed tonight has to do with inequity. And much of that inequity is racial, and it's linguistic, and it's by status, but it's also by gender and by sexual identity and by geography, because the health system in Eastern Connecticut, Northeastern Connecticut is very different from the health system in South Central Connecticut. We have serious equity issues in this state. And our next conversation, which I invite our audience to come back for and to bring friends and families to, is going to include Takesha Everett, the Executive Director of Health Equity Solutions, which is focused on making sure that everyone in Connecticut achieves optimal health through equity. And our State Comptroller, Kevin Lembo, who in his role as State Comptroller has exercised significant leadership on this issue of affordable quality health insurance, and is a major champion of the public option bill that we were talking about earlier today. He's also formally the healthcare advocate for the state of Connecticut. So please do come back. I'll have the pleasure of moderating that conversation again. I want to thank each of you this evening, Susan, Sarah, and Steve. All of your names start with S. But thank you very much for your stories, your insights, and I hope that our audience has enjoyed learning and has become charged up. I think as infuriated as Sarah expressed feeling, because this really should be very enraging to all of us. This is not just something that is at the intellectual level. It needs to be in our heart. So with that, I'm going to say goodnight to everyone. Thank you.
Great. Thank you, Frances.
Good night.
Good night.